Okay, so this is a very old picture, historical picture of the old ventilator. That is a negative pressure ventilator. So the patient have to lie inside and it just create a vacuum. Because of the vacuum created inside, the intrathoracic pressure decreases, which sucks in the air, and that's how the ventilation continues. I will not go in the detail. Just let's move forward. This is the normal respiration, or you can say the spontaneous ventilation. What happens in our natural spontaneous ventilation, the physiology, the brief physiology is that the intrathoracic pressure becomes negative. So it happens that air comes in and the lungs get filled. And after that, because of the elastic recoil and good compliance, it will get out of the lungs. Over here, as you can see. So it is because of the pressure difference inside and outside. Inside is pressure is negative and outside pressure is positive. So it will come inside. In the spontaneous or natural respiration, I will repeat again, the inspiratory phase will be longer than the expiratory phase. And while in the ventilatory breath, the mechanical breath, usually we set it at shorter inspiration and longer expiration. If anyone can tell me the reason why we do that, in the chat box, you can answer. Shabir has said that to avoid breath taking, and Dr. S has said to prevent air entrapment, stalking. Okay, that's an answer, but there's another reason as well, if anyone can tell. While we're taking the spontaneous respiration or patient is taking the spontaneous respiration, it is negative pressure. That's why I have mentioned it earlier in my slide, that the spontaneous respiration is a negative pressure ventilation. So what happens here, during inspiration, intrathoracic pressure decreases. So it won't affect the hemodynamic, it won't affect the cardiac output, it won't affect the venous return. While over here, what's happening? It is positive pressure ventilation. The air is being blown into the lungs, into the alveoli with a positive pressure and with a very high flow than normal, which may lead to increased intrathoracic or transpulmonary pressure, which may lead to decrease in venous return and cardiac output. Now, coming to our main topic, that is the that is the graphs. Now, there are different kind of graphs in the ventilator that we can find that ones are those also known as scalars, like scalars, or you can also call them curves, while the other ones are loops. I will tell you that what are the curves and what are the loops. This is a diagram in which you can see there are the graphs showing the curves, or you can say the scalars. And this is a loop. Now you may have a question in your mind that what is the difference between a scalars, a curve, and a loop. Scalar is also known as curve, okay? So I will use the term curve and loop. So what is the difference? I will tell you in my next slide, but let me show you that what kind of loops we have, what kind of curves we have. Okay, we have here, we have the pressure curve, we have the volume curve, and we have the flow curve. All are plotted against the time. So this is the pressure time curve, this is the volume time curve, and this is the flow time curve. So these are known as the curves. Now we have a loop here, and it is plotted against volume and pressure are plotted against each other. So it will give us a loop, a closed loop, as you can see. I will describe it later. This is another diagram of a loop, just to explain its different parts. That doesn't come under the scope of our lecture today. Our lecture is about the curves and scalars and so many other things. So you need to understand two things. First of all, we have constant and we have variables. I will show you another picture Let me show you this. Okay. As you all know that this is a graph paper, the typical graph paper. It has two axes. This is the horizontal one, x-axis. This is the y-axis going down. This is the positive side. This is the negative side. This is the positive side. This is a negative side. Now, what do we need here? We need two different values. One value to be placed here and one to be placed here. Now, among these, when we call it a curve or scalars, we call it a scalar when one of them is constant and the other one is variable. Okay? All right. The one value is constant and the other value is variable. And when we call it a loop, when both are variable, though both are changing. Got it? I will repeat it again. Don't worry. Going back to this slide. So what do you need to understand is that we have a constant and a variable. What do you understand by a constant? You think some value is constant because it's not changing? You all think that. But let me tell you that a constant is a value that changes, but that change is fixed. While the variable one, it changes and its change is not fixed. Got it? The constant value will change. Of course, it will change. This parameter will change, but this change will be fixed. All right? This change will be fixed. But over here, the parameter that is constantly changing, every second it's changing, it is variable. I hope I have just cleared the difference. I have made it clear, the difference between the two. So variable is plotted against a constant and it will make a curve. Okay? I will repeat again. The variable which is plotted against the constant, it will make a curve. And what is the constant here? It is time. Now you will ask, how come time is constant? Time is changing. Yes, time is changing, but time is changing at fixed intervals. 1 second is 1 second. You cannot change it. 1 hour is 1 hour. 1 minute is 1 minute. You cannot change it. So the time, of course, time is a variable, but it's constant. The changing happening in the time, it's fixed change. While the pressure or the volume or the flow, they are changing every second, every minute they are changing. All right, I hope I have made this clear. What we have here? Now, we have 3 curves and we have 2 loops. Okay. Now, we have which 3 curves? I have shown you the first diagram in which I have shown you the pressure time curve, then there was flow time curve, and then there was the volume time curve. While the loops, we have the pressure volume loop and we have the flow volume loop. All right, got it? So let me show you that picture again. Here you can see we have the pressure time. This is pressure, and over here it's time. This is volume. Over here it's time. That is constant and that is variable. Over here we have flow, and against time, time is constant. It's changing, but change is fixed, while its change is not fixed. It's changing every second. So these are 3 curves we have. Okay, let's go to the next slide. So this is the x-axis, this is the y-axis. As I've already mentioned, this is a positive side, this is a negative side. And as I have mentioned earlier, that spontaneous ventilation is a negative pressure ventilation. So how the graph will be created in a negative pressure ventilation? Because inspiration, at the time of inspiration, the pressure is negative in the intrathoracic cavity. So we will have a downward deflection on the negative side. And expiration, while expiration, what will happen? The intrathoracic pressure or the you can say the pressure in the airway will become negative. Sorry, it will become positive. So it will go up like this. Got it? Let me do it again. During inspiration, because of the intrathoracic pressure is negative, we will have a downward curve while inspiration, and while expiration, we will have a positive curve on the upside. You got it? That's easy. Now just remember this, because we will encounter we will encounter this thing at so many places now. Okay, let's move to the next slide. As I have already told you, so this is the negative breath, that is inspiration, and it goes up. This is the expiration. So that's easy, I hope. Let's go forward. Now, what is this? This is a controlled breath. You can call it a mechanical breath. You can call it a ventilatory breath. All right? Mechanical breath, controlled breath, or ventilatory breath, all are the same things. Just ignore this. We will discuss it later. What is time trigger? Just ignore this. Okay, about this graph. As I have already mentioned that the mechanical breath is a positive pressure ventilation. So when we plot the graph between the variable pressure and the constant time, this picture we will get. It will start from here, 0. This is the baseline. It won't go down. Of course, it won't go down. How could it go down? It will be on the upper side because it's positive. So it will go here. And after reaching the maximum during inspiration, it will go for expiration. After expiration, during expiration, it will fall down to 0 again. Okay? Yes, it's positive. So this is the mechanical breath. Now, let's see. Let's compare them both. Now, if we compare the spontaneous breath with the mechanical, or you can say the ventilatory breath, you can see the very clear difference that a spontaneous breath will be with a negative deflection, and then it will go towards a positive one, while the mechanical breath, the whole cycle will be positive. Inspiration as well as expiration, nothing will go down beyond this level. All right. Okay, now let me show you another slide. Now, this is assisted breath. There are two kinds of modes in our ventilators, spontaneous or assisted modes, and the second one are the control modes. So there are assisted modes which are used for weaning or to assist the patient's breath. How we will have a pressure graph for assisted breath. Now you can see here, it is the patient initiated breath. All right. Patient has inhaled a little. So as patient has inhaled, we got a negative deflection. As soon as patient has taken this short breath, immediately the ventilator will pick this, it will lift it up, it will take it up, and then there will be expiration. All right. So when the patient is spontaneously breathing, or patient is trying to breathe spontaneously while being on ventilator, patient's breaths will not be of adequate tidal volume. That's why we use assisted modes, assisted ventilation. What they will do, as soon as the ventilator senses that patient has taken a breath that is a negative breath, ventilator will immediately pick this up, take it up, full inspiration, and then after reaching a certain level, expiration will happen. Got it? So this is the pressure curve of a patient on assisted ventilation. Either it's assisted control, it is SIMV, or whatsoever. Now, what is the difference between the pressure curve for assisted and controlled? It's easy now. I hope you will now easily recognize it. The one with a negative dip and reaching to the top, going higher, it's assisted ventilation pressure graph or pressure curve, while without any negative deflection, without anything crossing beyond 0, only going up and then going down, not crossing the line, not crossing the baseline, not going down zero is controlled mechanical ventilation or ventilatory breath or controlled breath, mechanical breath. And the one that is lifting this negative, the one mode, the one which is lifting this negative one to the top and then letting it down, this is assisted ventilation pressure curve. Now, all three are in the same diagram. This one, as you can see, the small effort by the patient and the small volume or the small pressure patient is trying to keep up, to open up his airways. This is then ventilator has picked that small effort. It's taking it up, lifting it up. This is the assisted mode, assisted pressure curve. And then when you see nothing going beyond zero and it's totally positive, it will be controlled or controlled mechanical breath. Okay, I hope until this slide, everything is clear about the pressure curve. I hope you all are with me. Now, if I ask you to draw here, how will you draw? Let me help you. This is negative, and then we will have this one. This is inspiration, this is expiration, okay? Assisted mein kya hoga? Okay, what will happen in the assisted mode? It will go down, it will come up like this, and then this, okay? Inspiration, and then ventilator will pick this inspiration over here, and then it will go down. And in the complete controlled mechanical ventilation, it will be like this and this, okay? I have drawn it very nicely for you. Now, consider your lung, not your lung, the patient's lung as a balloon, okay? This is a balloon. This is patient's alveoli or patient's lungs. Consider it as a balloon and consider the ventilator is blowing air in a balloon, okay? So what will happen? Okay, as you start, or the ventilator start blowing into the patient's lung, the pressure will start rising. As you can see here, the pressure has start rising. Let's say you have to blow the 500 ml of air into the balloon. Okay, as you set the tidal volume on the ventilator, let's say it's 500 or let's say it's 400. So the ventilator has to deliver this. The ventilator has to deliver this 400 or 500 preset tidal volume to the patient lung. It have to blow that air into the patient lung. So what will happen? As it started blowing the air, the preset tidal volume into the patient's lung, the pressure will start rising, and it will rise to, let's say, it's 30 centimeter of water. Okay, so it reaches here. So what is this? This is a maximum pressure of the airway that is achieved, also called peak pressure, also called peak inspiratory pressure. So it has many names. You can call it the maximum pressure, the maximum airway pressure, Pmax. You can call it peaked inspiratory pressure, or you can call it peak pressure, P peaked. All right. So this is it. Now you will start. Now what happened here? The whole 400 or 500 tidal volume has been pumped or blown into the lung or the alveoli. Now it has to come out because the blowing period is turned off because it's time cycled. So after a specific time when the whole volume is blown into the lung, and after reaching this P max or P peak or PIP, it will start falling down because the air is coming out of the lung now. So it will fall down and it will come to the zero level again. Okay. So if I may draw a graph, or the pressure is rising during inspiration and the pressure and then the pressure is falling during expiration. So we will have such kind of a diagram or such kind of a graph. Okay. Let me clear this picture. Okay, as you can see, as I have already I have drawn the graph on my previous slide. So it is already drawn here. So it reaches to the maximum, let's say 30, and then after fully blown, and after a certain time, that is, let's say we have set the inspiration to 2 seconds or 1 second, to reaching the 1 second time and fully blowing 400 tidal volume into the lung. Now it's coming out. As it comes out of the lung, this pressure will start falling. That's very simple, and that's how it will look. Now the important thing, let me take you to the other slide. Okay, that's inspiration, that's expiration again. Now this. Okay, what is this? Okay, this half part, this half part, this side is inspiration and this side is expiration. Okay, let me use this other marker. So this half part is inspiration and this half part is expiration. And if we say how much time is used for this inspiration, we will write it here as Ti, the time required for inspiration. And if we say how much time was needed or how much time was utilized for full expiration, we will write it down as Te. Te is time for expiration. And the very interesting thing is if we just collaborate them together and we just can write them like this, Ti over Te, what will this become? Does it look does it look familiar? It is I-E ratio. Okay. These are the slides. Okay, now comes the most important part. Normally, the normal value, we just set the normal value on ventilator around 30, sometimes 35, but usually it's 30 centimeter of water for the PIP or the airway pressure. What if it goes higher? What if it goes higher? So can you think that we have blown an extra amount of air into the lungs? Or you can say the ventilator has to work harder to, or the ventilator is facing resistance and it has to work hard against resistance to blow the air into the lungs. So can you say that? First of all, the most easiest thing or the most common thing coming to our mind, it will be that either the ventilator has to work hard against something, there is something wrong in the passage or in the tubing, that ventilator have to exert this much pressure to blow the air into the lung, or either we have set a wrong tidal volume, we have set a higher tidal volume, so the extra amount of air getting into the lung, and that is causing the rise in pressure, the airway pressure. Okay, to make this concept further clearer, let me explain this. As you can see, this is a very neat diagram of the whole airway system. This is the tube and this is the balloon. These are the balloons. Okay. Let's say this is my ventilator tubing circuit and this is my ventilator. Okay. It is blowing air inside. So there may lie a problem over here. There may lie a problem over in this part, or maybe in this part. This is the parenchyma, alveoli, the connective tissue, and this is the pipe, the windpipe. It is the airway, trachea, and then bronchioles, bronchi, and the bronchioles. So there may be anything obstructing here. There may be excretions. There may be foreign body. There may be mucus plugs. there may be inflammation, that anything that may cause narrowing of the passage will increase the resistance and the work of breathing, and the ventilator have to work hard for that to fully blown or to deliver the tidal volume. And then again here, if there is any problem here lying in the alveoli, the tissue, the parenchyma, again the pressures will be higher. Okay, tell me what happened. If we were expecting this, and we get this. Okay, we were expecting this, it should be 30, but now it's reaching, the P peak or the pressure is reaching 40. What will you do? The mostly I have seen people, they just go to the vent and they turn off the alarm and they go sit back and just continue with whatever they were doing. Please don't do that. Okay, you don't just have to turn off the alarm. You have to see the patient and the problem, there where lies the problem. Yes, you have to rule it out. Yeah. Now, what do you have to rule out? Which thing do you have to see? For that, you have to you have to check the P peak, PIP, and the P plateau. Okay. And how you will see this? Yes, you all are answering right. But for that, how will you identify that it's a problem of tube and you need to do suction, or you need to check the ventilator, or you have to auscultate the chest? Of course, you have to do all these things. But if your patient is not crashing, and if your patient is hemodynamically still he is stable or she is stable, then what will you do? You have to differentiate between the cause. So it will help you manage the patient and help you diagnose or reach the problem. And how will you do it? You will do it through, you will check the plateau pressure. And how will you do it? Can do anyone know? Okay, let me tell you. How will you differentiate between, how will you identify the P plateau? And then you have to see the difference between the P peak and P plateau. And you can do it through, and inspiratory occlusion, Barza is right, inspiratory pause. Yeah, I have put this slide here. I have put it here like inspiratory pause. You have to press the inspiratory pause option, and then you will get this kind of graph along with the value. Don't worry, you don't have to describe it. There will be a written value or digit value in the digit form. Like let's say it will be written as like pip is 40 and P plateau is 25. If its P plateau is 25 and PIP is 40, it means the difference is too much between them. Okay. So it means that the causes are relating to resistance. There is increased resistance. And if it is not 20, it is, let's say it's 35. It's 40 and it's 35. The difference is very low. Both are, the values are corresponding. It means the problem lies in parenchyma. ARDS, pulmonary edema, interstitial lung disease, anything like that. So this is another graphical presentation. I have put a lot of slides to just make sure that your concepts are clearer. When inspiratory pause is done, okay, we just perform it while inspiration, because we have to hold the inspiration. When the inspiration starts on ventilator, we just press, touch, and hold the inspiratory pause button. I will show you. It's in demo, so don't worry about it. Okay. You just have to make your concept clear, because all of these are related to the things that can cause airway increase in the resistance. Like you can see here, if the circuit is kinking, of course, it will provide resistance. The fluid pooling, the mucus secretions in the circuit, of course, it will narrow the pathway. If the patient is biting or clinching the ETT, of course, it will narrow the tube again. A small diameter tube and a larger tidal volume, laryngospasm, bronchospasm, mucus plugging. Now, these are the relating to the compliance problems. When there is high peak, high PIP and high plateau, both are raised. So what can happen? the tube, you have set the tidal volume at 400 for both lungs, but now the tube is in one lung. So what will happen? Of course, it will raise the pressure, and it's going into the 400 tidal volume is going just into one lung through the mainstream. Pneumothorax, pulmonary edema, air trapping. Yes, of course, air trapping, ARDS, everything. These all things, as you can see, all these things, they just compress the lungs, either due to the air trapping increase in the increased air inside, or fibrosis, or inflammation, or abdomen compartment syndrome, or obesity. Because of these last two, the compliance decreases, and then you will have the picture of high PIP and high plateau pressure. Now we are on the flow curve. It is very interesting curve. It's the concept behind the curve is even more interesting. You can see the buckets, and you can see the balloons here filling with the water, and then we are trying to empty it. Now let me tell you, what do you think is flow is? The ventilator gives a tidal volume like a syringe injecting air into a balloon. Do you think like that? Now we're talking about the flow. Okay, flow. What is flow? It's not like that. It's more like a running water tap that is filling a bucket, or more precisely, you can say it's filling a balloon. Okay. Now, what happened here? Okay, what happens here that when you turn on the tap, when you attach a balloon to a water tap, the water start flowing into the balloon. So it will start distending. It will be filling at a rapid pace. And then after a certain time, as you can see in the second one, the filling will be constant. It will reach a plateau. And then after that, when it will be filled to its limit, and we will just turn it upside down, the water will start gushing out. Now, when the water will start gushing out, there will be a rapid fall, and that will be followed by very little volume of water left inside the balloon that will start dripping drop by drop out of the water, and it will take some time to leave the balloon or let the balloon be empty fully. This is the graph. Don't be scared of it. It's very interesting graph. It has two parts. This part, that is, you can say the upper part of the graph, we can say that is the positive. And the lower half, this lower half is a negative. Okay? You all agree with this? The upper half is positive and the lower half is negative. Now, what's happening here? Now, consider that balloon and water thing again. Just imagine that you are pouring the water into the balloon. In the initial phase, it will be distended rapidly. So this is rapid distension, inspiration. Then after some time, because of the compliance of the balloon, the flow will become constant. And then when you will just turn it upside down or inverse it, there will be a rapid fall with a gush of water coming out. It's a rapid fall, as you can see. Let me see this on my screen as well. Yes, okay. Then there will be a rapid fall, as you can see here. And that will be followed by a little volume left inside the balloon, and that is coming out very slowly, and it will take some time. Got it? So this is inspiration, rapid distension, constant phase, then rapid fall, and then there is slow expiration. It will take some time. Now, what is this? This thing is the peak expiratory flow rate. What is peak expiratory flow rate? That you use to check for the asthmatic patients. PEFR. This is PEFR. The first rapid fall, the peak expiratory flow that reaches to the maximum during the first fall, it is the peak expiratory flow rate. And then it followed by the slow expiration time. Got it, everyone? If you just got this, understand this, I will go further. Another one with further elaboration. The upper half, where the air is getting into the patient, out of the ventilator, towards the patient, away from the ventilator, it will produce a positive deflection. Now, the lower half, air is getting out of the patient, it is going towards the vent, so it will create a negative deflection. Expiration, this is inspiration. All right. So this is another explanation. This is in the volume control mode. You will have this kind of shape. And while in the pressure control or pressure support mode, you will have this kind of shape. Now, why it's like this? You may have a question that why it's not the same, because there is a drop of 25% of peak flow in the pressure support mode, and the ventilator cycles to expiration at this flow rate. Now, what happens when there is resistance, and what happens when there is lung compliance issues? Now, as I have elaborated for the graphs of the pressure. Now I will elaborate the same conditions, resistance and compliance, that how they will affect the shape of the flow graph. This is the normal one. As you can see, rise, constant, fall. First fall is the rapid gush, followed by the slower one. Now, what happens when there is resistance? The inspiration will be same, almost same. The problem start when the expiration starts, because in the conditions like asthma or COPD, usually there is problem related to the expiration, and there is always air trapping. So what happens there? There will be no rapid fall, and and if there will be a rapid fall, it will be very limited. This won't go further, just like it's going further down in the normal one. In the airway resistance, where the airway resistance is high, or there is obstruction, or there is inflammation, and the pathway is narrow, the tube is narrow, the expiration phase will not be as rapid, and it will not reach to that level that it normally reaches in the normal lung or normal airways. So what happened here? This limb will be shorter, and it will take more time than the normal to fully exhale or fully empty the lung. Okay? This will be shorter, and this will be longer. So I will show you a graph that we have on our ventilator here. Here you can see that this is the normal inspiration, and then it's going down and reaching the level, and then it's the fully expiring out, fully exhaling out. While you can see here, this expiratory limb is shorter, while the other one, this one, is taking this much time. Can you see? It's taking this much time. So you can fully appreciate the difference between the two. Can you? Kindly let me know in the chat box that you have fully understand this. The next. Now, this is what happens when there is a problem with the compliance. In this, the lungs are stiffened. As you know, in the problems where the compliance is the problems, either the lung is stiffened, or they don't have enough space. So what happens? They will show there will a very rapid fall, a very sharp fall, because the lungs are too much different, that they will push out the air very fast, very rapidly, and it will reach the peak, the PEFR. And while there will be very little volume will be left inside the lung, and it will be empty very early. Now I will show you all three, and you will tell me which one is which one. Now tell me which one is a normal, which one is the problem with the lung compliance, in which diagram is showing the problem with resistance, air resistance? Kindly tell me in the chat and then I will go further. Okay, everyone is saying C is normal. A is normal. No, Jennifer, A is not normal. The C is normal. Okay. C normal. B is spasm. B is spasm. Yeah, B is spasm. A is not obstruction. Pradeep, A is not obstruction. A is ARDS. Yes, A is ARDS. A is lung compliance. Good. Yes, very good. I'm happy that you all have learned this.